Hi. Per the National Cancer Institute's statistics, the projected number of cancer diagnoses in the United States for 2024 was more than 2 million, and the number of cancer survivors by 2032 is estimated to be approximately 22.5 million. The estimated national expenditure for cancer care in 2020 in the United States was $208.9 billion, more than the GDP of over 150 countries worldwide. This is not the healthcare expenditure. This is just the cancer care expenditure for 2020. Needless to say, cancer management has become a societal issue with its multifaceted and diverse set of challenges. Oncologists are not only physicians, but a pivotal part of our society. Unfortunately, we have not done enough to maintain or revive the well-being of our oncologists or our profession. A survey conducted by the prestigious American Society of Clinical Oncology reported a significant deterioration in the professional satisfaction of the oncologists, with over 59% oncologists reporting one or more symptoms of burnout in 2023 compared to only 34% in 2013. Additionally, around 1,748 community clinics and or practices have closed, been acquired by hospitals, merged, or reported financial struggles since 2008. Welcome. My name is Jasmine Kamboj, and I am a medical oncologist and hematologist in the states of Minnesota and Wisconsin, and your host for the conversation today. Empowering Oncologists is a podcast brought to you by OncoDaily, where we will focus on day-to-day concerns of an oncologist's being and workflow with a vision to find sustainable solutions. We hope to share our stories of wins, losses, resilience, and inspire and empower our community because we fly higher and longer when we fly together. Before we dive in, a disclaimer. The views shared on the podcast are an individual's and in no way are contributions from any institution, organization, or guidelines. For our session today, we have Dr. Eric Bernicker, who is the Enterprise Medical Director for Medical Oncology for the Common Spirit Mountain region in Colorado. Prior to that, he was at the Houston Methodist Hospital in Houston, Texas, where he oversaw lung cancer trials. He has served on the collaborative expert panel of International Association for the Study on Lung Cancer, also known as ISLAC, with CAP and AMP for biomarker testing in lung cancer. He has edited 3 textbooks and served as the chair of ASCO's Climate Change Task Force and as a liaison to the Medical Society Consortium on Climate and Health. In his free time, he likes to ski, hike, and bake bread. I have personally had the honor of working with him on the task force with ASCO, and I have actually worked and trained with him as a fellow in my fellowship at Baylor in Houston. Welcome, Eric. Thank you for being here.
Thank you for having me. Pleasure to be here.
Tell us about your current practice, Eric, in Colorado.
So it's been an interesting transition, but I would say right now I'm about 50% clinical, 50% administrative, which means I'm about 75% clinical and 75% administrative. So I oversee the expansion of our medical oncology program across Colorado, Kansas, and Utah. And Common Spirit's got a growing focus on cancer care. Some of our hospitals are urban-based and some are much more rural, and each have very different and very unique problems, which we can discuss. And then I'm finally back in the clinic again, about 50% of the time at our Northern Denver hospital, seeing general medical oncology and some benign hematology as well. So it's been great to get back in clinic, and it's been a very eye-opening transition and experience.
What prompted you to transition from Houston, the big city life, to the softer, quieter mountain life in Colorado?
It's It's interesting. When you're in Colorado, Texans are an annoyance, right? They all come up here and ski and hike, but now I'm on the other side. I think there are a couple things. So without delving into it too much, I would say this. You hit your late 50s and you start thinking about how do I want the last third of my career to go? I had a great gig at Methodist. I really enjoyed it. I had outstanding colleagues and collaborators. Um, but you do start having these, whiffs of mortality and thinking, what else can I do? And then at the same time, both my parents were dying of very advanced dementia. And so that also has a way of, focusing on enjoying life when you can. I think we've all seen docs who waited a bit too long to retire and then they didn't thrive in retirement. And since my wife and I love to ski and hike, and it's very hard to do that in the Gulf Coast of Texas, when this opportunity came up, both the professional opportunities for leadership and being involved in a growing program, combined with, again, just the beauty of Colorado, it was hard to say no.
So that's actually a lot of great points you bring up. One is that it's always great to have a combination of clinical and administrative and leadership opportunities, because that not only gives you the say in trying to create your practice or how you want to create it, right? But also helps mitigate burnout, right? Because you kind of you're seeing both the worlds.
Yes.
The other thing that's a really good point is that don't wait until you actually get to that edge of burning out, right? We are all human beings also. We all have families. So our families and our personal choices do have a say in our professional choices that we make. So that's a great way to look at it, that you are mindful of that.
I agree completely. I think that part of my role is to recruit physicians. And so I spend a lot of time talking either, again, older career folks who are looking for a move, fellows trying to figure out what do they want to do and where do they want to go. I think many physicians are very conservative by temperament, and they're sometimes very scared to take a plunge and to move on. It's a bit different, I think, excuse me, in hardcore academics. Obviously, a lot of those folks eventually are going to move to new institutions and work their way up. And that's a slightly different situation. But I think a lot of clinicians, they kind of get in a groove, and there are factors that conspire sometimes against them moving or taking new opportunities. Part of it is they don't want to leave their patients. I mean, I had been practicing in the Texas Medical Center for, should I use this term, a quarter of a century. And so I'm not saying it was easy to tell patients I was moving, right? Not that there weren't other wonderful oncologists for them to establish with, but you do have some degree of, and this is important, commitment and a little guilt. But at the end of the day, I think people, they need to find the right situation for their fulfillment. And that's not just professional fulfillment, right? They have to make sure that they're really thriving personally and professionally. Those statistics that you had mentioned are eye-opening and horrifying. I think if you speak to the average med-onc in the trenches, they love their patients and they absolutely love the science. And I am very glad I now practice in a world where we do outpatient chemo and have immunotherapy and have targeted therapy, because I remember when we didn't have that. But at the end of the day, there are so many other things that can conspire against job satisfaction.
Right.
And we'll talk about this, but now I'm on the other side. I don't want burnt out docs because I'm selfish and lazy and they're going to leave.
Right.
Then I have to recruit again. So it's important for all of us to keep people as satisfied and as kind of supported as best they can.
Right. I do want to reiterate here, thinking about yourself. And so first of all, our careers are so long term, right? We do 3 years of fellowship not to burn out in the next 5 years, but to have a 30-year long career at the least.
Right.
And with the longevities that we're seeing, it might even be longer than that. So we have to be mindful of that, both when we are choosing a job and when we are recruiting for a job, right? And I feel like, up until a couple of years ago, we were just instilled with this as a physician. We're instilled with these guilts or these thoughts that we cannot think about ourselves, but that's not helping anyone, not even our patients. So I feel like it's our responsibility towards our patients and ourselves that we're mindful of these choices. So
look, I'm old enough to remember, and of course, I was not a general surgeon, but in the old days, when I was at Baylor had a very hardcore surgical program under DeBakey. And if I recall, the first 2 years of their general surgery residency was every other night call, 1 day off a month. And if you complain, the argument is, well, you miss half the cases.
right.
So, but you're right. We're very good at teaching people the scientific side of all this, and that's certainly important. I mean, I'm not saying we need people who are not fully up to date on what's going on, but we don't necessarily, and we have to mirror this too, or project this. People should not be on Epic clearing out their inbox when they're on vacation, and it's okay
Right.
to not work in every last patient because you're pathologically afraid that if you turn down a consult, you'll never see another consult. And by the way, I have firsthand experience of that because I did that for a long time in practice. So I think that you're right. You have to take that long view of what's going to satisfy someone over a 30 or 40-year career. Doesn't mean they have to stay in whatever initial situation they find themselves in. But this is an ultra marathon, and you have to pace
Right.
yourself. And we don't work on teaching fellows how to pace themselves, right? In fact, the ones who don't pace themselves and are writing, paper after paper and grant after grant, and that's great, by the way. But my point is, we reward people often.
Right.
The people who take on the most responsibilities, serve on the most committees, see the most patients. Everyone's got to figure out what works for them.
Right.
But again, a burnt out academic who leaves their career, or a burnt out doc who is doing a less than satisfactory job in clinic, it's not what any of us need.
Absolutely. Yeah, we're not doing any service to our patients if we are burnt out ourselves.
We're
Perfect.
not.
Yeah.
We're
So we're also facing this new wonderful challenge, I would call it, because this is a good problem to have with immune therapy. We're having more cancer survivors, which is awesome, but also an inflated population to cater for. How do we utilize the current existing partnerships that we have, like our primary care physicians or our APP folks, specifically in smaller settings or rural areas? Like, what's your take on that, Eric?
So it's true. Again, when I went into practice, survivorship wasn't that much of a thing because there weren't a lot of survivors. I mean, without being super negative. So it's a blessing that we now have so many people either actively on therapy or years out. I think the workforce crisis, both in rural America, but even in major cities, I just don't think we have enough docs, and so it's going to be imperative. Going back to what we've been talking about, avoiding burnout, is working with our primary care colleagues that once patients are transitioning off of active therapy, to collaborate with them to do a lot of the survivorship care. I mean, are there other ways to do that? Sure. Could you have a number of survivorship clinics kind of staffed by, advanced practitioners? Sure. Yes, we can do that. I do understand that this means a lot more communication. I think that both with, by the way, patients and caregivers, it's not that the oncologist doesn't want to remain involved. I think we would all say some of the greatest joy we have is seeing the person 5 years out, 8 years out, you come back and you spend time looking at vacation pictures, not discussing active therapy.
Absolutely.
But we have a bandwidth problem here. And so I think that there needs to be a concerted, it started, but a concerted ongoing effort to really work on how cancer survivors get the care they need, have long-term follow-up. But a lot of that is just not going to be necessarily delivered by medical oncologists who really need to be seeing the acute newly diagnosed cancer patients and, of course, monitoring their therapy. If I had a magic wand, I would make major changes in our workforce, and I don't. So I think we all have to put our heads together. This is going to be a huge ongoing issue as more and more survivors, as those numbers balloon. But we've got to be really thoughtful in how we make sure the quality of care is outstanding, make sure our primary care colleagues feel that they're comfortable providing a lot of that survivorship care. And we'll do that, but it's going to make a big change. Traditionally, that's not what medical oncologists have done.
Right, right. So, and to include them and collaborate with them, we have to also train them. So that's another part. And then we have to also make sure it's not only the oncologists who are feeling burnt out. Primary care physicians are unfortunately also feeling burnt out, and so are APP colleagues as well. So training them, making sure they're not burnt out, making sure that they have we have enough number of them as well around. So that I'm going to pivot to our next question. So we have my understanding is we have around 600 fellows that graduate every year in the US. How can we work with ACGME or these organizations to increase the fellowship spots or funding, not only in oncology, but other areas as well? Why are we not having more medical students?
So I need a lot of magic wands, and this would be another one of those. Look, I think that for most of us who are, again, in the trenches, we're aware of this problem. I don't know how much of it has filtered up. It's quite expensive to train folks. We get that. And I should point out, by the way, it's not just rural medicine. That's a whole nother topic. Yes, it's very hard to recruit to some rural areas. A lot of specialists and primary care who've always done their training in major medical schools in major urban areas, done their residency fellowship, they might not want to move to a rural place because maybe you can't do goat yoga or get whatever. But the point remains that it's a huge burden on our patients. I think that, by the way, academic centers are having trouble hiring junior faculty. So this is a problem that academic, clinical, practice, it's affecting all of us. So I think in the short term, I don't think we're going to magically start minting or significantly expanding slots. So I think we have to do a couple things. One, we have to keep old people like me from retiring early. So there's got to be some creative ways to keep docs who maybe want to slow down. So in a lot of practices, quote, slowing down is super difficult, right? Because maybe you don't want to take call like the younger guys do. And maybe you want to work 3 days a week, but you don't want to pay the same overhead. So that being said, we have to keep experienced docs. Even seeing part-time helps with that flow. I think we're going to have to be very inventive in how we utilize telehealth. I know that's a whole ongoing issue in Washington, but certainly you could foresee ways where rural patients can maybe be seen in the big city and then go back home for their treatment plan and have maybe an APP supervises their infusions, and you're doing toxicity checks over the magic of telehealth. I think there's going to be an expanded need for nurse practitioners to really help deliver routine follow-up and help do consults. That's a short-term solution. I don't disagree. We're either going to have to import a lot of foreign doctors to help staff as the population ages, and as we see more cancer in younger people too now.
Right.
But we're going to have to relook at how we fund and how we expand fellowship positions. I
Right.
think that if there were more positions, I think they would certainly fill, meaning even with the data that you had mentioned about the burnout, I really think the majority of med-oncs feel humbled and privileged to do what we do. I'm not saying other specialties don't, but most of us love what we do. We might not like peer-to-peer and dealing with the electronic medical record always. I get all that. But when you're in the room with the patient, there's, I think that constantly reminds us of why we do what we do. So
Right.
I think we also need to continue to have exposure to medical students, make sure that we're really showing them the joys of a career in oncology. But ultimately, it's going to have to be telehealth, expanded, collaborators from NPs and just making sure that patients are getting the care they need, ideally closer to home, right? I mean, I think we're finally focusing on, this is a loaded term, but the patient experience. And
Mm-hmm.
sure, there will always be folks who have to go into the big city for phase 1 trials.
Right.
But you and I know that a lot of patients can get their therapy closer to home,
Absolutely.
especially with palliative therapies. Spending a lot of time in the car, schlepping in to get your infusion or daily for radiation can be very difficult. And so how do we balance that? Well, you'll be talking about that constantly on this podcast, but that's part of our real goal here, that we need to make sure that no one's getting left behind with these developments in cancer care, and that we can make sure rural and elderly folks can have the same access to care. I think that, so it's really interesting. There's no question that all of these factors, how do you get the right interest and the right economic incentives? How do you, but when I recruit these folks, I mean, don't get me wrong, they're interested in what their salary is going to be, but they're super interested. Do they get an admin day to catch
Right.
up on all their EMR stuff?
Right.
How often or how infrequently do they have to be on call? And yes, being an old cranky guy, this is not me complaining about the younger generation.
Mm-hmm.
They want to have time to do everything you said. I mean, they want to work hard, but when they're off, they want to be at their kids' little league game. And one great way to burn people out is to not be cognizant that we're all not just working machines, and that
Right.
whether it's exactly right, it's and now, does that influence workforce? Sure, yes, in the sense that you might have folks who over time are generating slightly lower RVUs, but in the long term, if they don't develop substance abuse issues or quit,
Right.
that is better for the system or the practice or the NCI designated cancer center. I'm not saying it's easy, but I do think setting realistic expectations, listening to younger career docs, and there has to be an openness. In medicine, we're super bad, I think, at asking for help, right? We're supposed to be iron men and women. You're not supposed to complain about call or being woken up in the middle of the night. And that being said, I think that from fellowship on, if you're over a bunch of high performing med-oncs, you got to stay in touch with them. How are you doing? We
Right.
appreciate what you're doing. What can I do to
Right.
help? And some things, I can't necessarily take over Epic and change Beacon builds immediately. That would be great. But I do think listening, making sure that all your employees are on the right track. And
Right.
if not, working with them, that investment in saving someone's job with your organization or your practice, I think is
Right.
crucial. I don't think, and I think you would agree with this. I don't. When people burn out, it's not from seeing critically ill or terminally ill patients. We chose to go
Right.
into oncology.
That
It
is so right.
is the time it takes to care for those patients. It's all the other things you mentioned. Is there time to hike or do yoga or go to, you know,
Okay.
whatever, your kid's piano lesson.
Right.
And that's true for nurses. That's true for pharmacists. I mean, that's the whole medical establishment is creaking with, you know, burnout, right? So I think it behooves us all to be as cognizant as we can that the whole health system ecosystem needs loving care, and we've got to be able to look out for each other
Right.
without sacrificing quality of patient care.
Absolutely. In fact, I actually strongly believe if we focus on the TLC for the physicians and our healthcare staff, in the long run, it's going to impact quality of patient care in a positive way. There's no way it would not happen. We'll pivot a little bit again. So congratulations on your FASCO status. For our listeners and viewers, FASCO stands for Fellow of American Society of Clinical Oncology. It is a status given to a volunteer who has shown their commitment over a long period of time to ASCO by doing, volunteer roles in committees and task forces. And Dr. Bernicker got the FASCO status this past year, so congrats on that. And how did you start your volunteer career with ASCO, and how was that journey for you, Eric?
So, I'd say, yeah, it took me a little while, but I finally hit the FASCO status. I got involved in ASCO initially early when I was in practice. I was on the clinical practice committee. It was a very valuable experience. And then there was a period of time where, while I was an ASCO member and going to annual meetings, I wasn't that involved. Usually, I would say a lot of that was just early in my practice that was growing, and the idea of more commitments just seemed to give me a headache. But again, it's kind of like with my move to Colorado, probably mid-career, I'm like, I have a good bandwidth now, and I want to give back. And whether that's going to Washington, D.C. with ASCO to meet with lawgivers and kind of help them understand certain crucial issues facing healthcare in general and medical oncology and radiation oncology specifically was great. I got to serve on the editorial board of the Journal of Clinical Oncology Practice. So it's, part of it's selfish and part of it's looking for meaning it's selfish in that it's fun to be involved in these projects and meet really phenomenally gifted other, folks from around the country. And so that was a fabulous learning experience. But it's also being able to use your skills and your energy to be involved in,
Right.
again, whether it's writing a policy position, being involved in guidelines. I mean, it's ASCO is one of the most respected, certainly of the oncology professionals community, and it's a leader in not just patient care and quality, but also in research. So it's been a real joy to be involved. Hopefully I'll keep creaking up to Chicago every June for the meeting, but it really added a tremendous amount. I will say this, I hate to keep kind of pivoting back to burnout. So it's really interesting. I don't think ASCO as a preeminent organization has difficulty getting docs to participate, whether it's, again, editorial boards of their journals or their committees. I do think because many physicians are so busy with their practice and trying to do all the things that we've been discussing, that I think some state medical societies, other hospital committees, it can be hard to convince people to get involved in those projects. And on one hand, I get that. You're not getting RVUs, you're not getting money. Not that I'm not trying to be venal, but at some point, as you're looking at your list of things to do, no one's really looking for more committee meetings necessarily. And yet I think it's very important, again, whether it's your hospital, whether it's, your state medical society, whether it's national committees, we need docs of all stages of their career, involved across the country to get involved in this stuff. And I don't have a great answer for that either, because again, it's not like you don't have these other things to do and you still have a kid's kickball game to go to. So I think it's important. I will tell you that when I was first in practice, the model was different. And I'm not in any way saying we should go back to that model, because I think a lot of those docs drank too much or got divorced. But the point was, it was family life kind of definitely came second to that generation of docs. And I think that's unfortunate. And I think the younger folks coming up in no way want to live like that. But we still have to find a way to get people involved through, whether it's ASCO, AACR, ISLAC, getting involved in local stuff. It's really important. And again, you just have to hope that people find the time when they find something they find meaningful and that they can be passionate about, that they have that time and can give back.
Right, right. One of my personal take-ons is that if we can alert and educate one person in our practice for these things that ASCO does and other organizations do, because ultimately they actually, even though they seem like you are taking on committee roles, etc., but ultimately they actually help you mitigate burnout. You have more networking opportunities. You just feel more rewarded and encouraged. And as human beings, we all have this natural instinct to contribute and pay it forward, right? And so ASCO does a really good job in doing that. And for the fellows and early career oncologists, I mean, the earlier you start, the better it is what I would say.
No question. And look, it's all of those things you said. I mean, it's personal satisfaction, being honest. There's also visibility. There's networking. There's the political side of academic as well as, clinical practice medicine. But I do think the earlier you get involved, the more you can see that and get, and don't get disheartened if you apply for an ASCO committee and you get nuked, because you probably won't necessarily get it on your first try.
Right.
But I think that especially for people such as you and me who've done this and have gotten just such great satisfaction and meaning from our work with ASCO, I think the fellows see that. But I also understand, again, when you are finally finishing your 100th year of training or whatever, and you're finally out in the real world, and whether you're starting the ascent on the academic side, whether you're trying to build a private practice, it's very hard sometimes to look at your schedule and see, well, where is this going to fit? And there might be some people where that's not a good thing for them to pursue. But if there's any way to keep that in mind and make sure that part of their professional world, meaning it's not just seeing patients or writing papers, but that there's a lot of other stuff that can be done that's really meaningful, that will improve quality of care, that will, hopefully, do I think speaking to my representative in DC changed federal policy? I haven't seen that yet, but my point is it's just always great every, April to go with your colleagues and to have that experience, to see how government works. Anyway, it's a joy, and hopefully a lot of younger career folks will get involved.
Absolutely. So a bit of a rapid fire for you, Eric. What's your favorite book?
Oh God. That's a hard question without sounding too pompous, but I would probably say The Brothers Karamazov.
Okay. Is there a reason for that?
I keep going back to it every so often. I just think Dostoevsky does the best job at describing the existential situation of humans. Yeah. It's great.
Got it.
Do I read it in the original Russian? I do not.
Favorite leader?
Favorite leader, Abraham Lincoln.
Okay. You are, this has come up the second time on this podcast already. And we've just started. Favorite study? Cancer study.
This is brutal. I would say I would say I would clump a number of them. I would say a lot of the early data coming out of EGFR and ALK
Yes.
studies in lung cancer, where it was demonstrated that a simple looking targeted therapy pill was vastly better than chemo, and just ushering in the age
Yeah,
of targeted therapy in lung cancer.
for sure. And favorite restaurant in Houston?
Um, that's this is going to be embarrassing. There are a lot of phenomenal restaurants in Houston. It's really a
Mhm.
foodie city.
Right.
But I would say my favorite restaurant is Kenny and Ziggy's, which is an old-fashioned Jewish deli.
Mm-hmm.
And any cardiologist listening to this would be absolutely horrified if they knew the pounds of pastrami and corned beef I've eaten over the years. But yeah, I'd say that.
Awesome. And favorite hiking spot in Colorado?
There's a wonderful hike just kind of near East Vale, Booth Falls. That's probably the most beautiful thing I've
Mm-hmm.
ever seen. I'm not saying I wasn't huffing and puffing at the end,
Uh-huh.
but
Yeah. Yeah.
there's no dearth of stunning hikes here.
In Colorado.
And we've been fortunate to take advantage of that.
And so going to the fun fact about you. What was your nickname in college and why?
I probably regret giving you this information. So my nickname in college was 2% because there was a poll of, I don't know, like 1,000 women in one of those magazines kind of targeting housewives. I think it was Redbook. Anyway, they asked women a bunch of physical characteristics that would define their perfect mate, and only 2% of women replied redheads. So I had some very cruel friends who decided that was now my nickname. So that was it.
Most friends in medical careers are brutal and cruel.
Yeah, you're right.
So
Absolutely
we all know that, right?
correct.
So, and if you were to relive your life, would you choose oncology?
Yes, absolutely. The only other thing is, if I could have covered the Yankees as a sports writer for the New York Times for 30 years, I would have done that. Although I doubt that would have been as meaningful. I would easily choose, I wouldn't have done anything different. I think that there's not a, without sounding too maudlin, there's not a day that I don't go to work, even if I'm complaining about a lot of stuff. I love what I do. I absolutely could not have seen myself doing anything else in medicine. It's been a privilege and a blessing to be a medical oncologist, again, at a time when things that we couldn't imagine when I was a fellow are now routine practice. And the impact it's made on our patients' lives have been immense. Do we have a ways to go? Sure. We're not
Yes.
there yet.
Right.
But yeah, I would sign up again in a second.
Wonderful. Well, thank you, Eric. Before I give my closing statements for our audiences, this is a book authored by Eric Bernicker on environmental oncology, and we actually worked a bit together on this as well. And this is the policy statement on the climate change and cancer by ASCO, also authored by Eric Bernicker and his task force when he was the chair at climate change task force with ASCO. And this was one of the best of JCO oncology practice. So it featured in the JCO best article. So I just wanted audiences to know that. So 3 key takeaways from our episode today. I'll try and be simple here. It's okay not to work during your vacation, folks. Take your time for yourself. And number 2, I think as leaders and oncologists, we need to get creative in terms of how we can bring in the retiring workforce and how we can make things easier and more lucrative for our younger workforce. So we can tap on the existing people until we figure out how can we find more spots for the fellows. And the last but not the least, leadership at these organizations need to start encouraging involvement and engagement with societies like ASCOs and others. And we may not be able to fetch RVUs during, doing some ASCO committee work and all. But again, these things have so many hidden rewarding things with them that come, in terms of enhancing your career and professional development, patient care, advocacy piece, that it's a lot of soft RVU that we build up through these committees and task forces and ultimately the FASCO status as well. Well, thank you so much, Eric, for being here with us. Thank you to our viewers and listeners. This is Jasmine Kamboj and Eric Bernicker signing off on behalf of OncoDaily from our conversation on Empowering Oncologists. Thank you.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.